This program is brought to you by Emory University.
Good morning. My name is Gautam Kumar. It gives me great pleasure to introduce my friend, mentor, former teacher who taught me how to do cardiac catheterization from Mayo Clinic, Dr. Patricia Best. Dr. Best is interventional cardiologist at the Division of Cardiovascular Diseases at the Mayo Clinic. She has numerous areas of specialties, including complex PCI, and she's also been heavily involved in research in SCAD or spontaneous coronary artery dissection. Without any further ado, please, Dr. Best.
Thank you so much, Dr. Kumar, and thank you for inviting me to give this talk on spontaneous coronary artery dissection. Today, we're going to talk on the diagnosis and management challenges in spontaneous coronary artery dissection. And so we're really going to kind of cover soup to nuts of everything that you need to know to manage and make the diagnosis of someone with spontaneous coronary artery dissection. I have no disclosures related to this talk. The objectives of this talk are to discuss the diagnostic challenges with spontaneous coronary artery dissection, to review SCAD treatment outcomes, and to discuss the follow-up management of SCAD. So SCAD was first reported in 1931 as a non-atherosclerotic cause of an acute coronary syndrome. It's under-recognized and underdiagnosed, and that's still true today, even though we are making great strides in people looking for it and starting to make the diagnosis. There are at least 800 new cases annually in the United States. Usually it affects young women with few cardiovascular risk factors, but it really can affect anyone at any age. The average age is 45 to 53. Up to 10 to 20% are peripartum, with the most common cause of peripartum myocardial infarction being SCAD. It accounts for 1 to 4% of acute coronary syndromes and 35% of myocardial infarctions in women under the age of 50. The pathophysiology is still poorly understood. In about 50% of people, there's precipitating factors. More commonly in men, it's intense exercise, intense Valsalva, and lifting heavy objects. In women, it's more common for it to be emotional stress. It can be also retching, vomiting, bowel movements, cough, labor and delivery, and recreational drugs. So I'd like to start with a case. This is a 47-year-old woman who presented with chest pain. It was central chest pressure radiating to her axilla. It occurred first thing in the morning while she was walking on the treadmill, which she did every day. She had no cardiovascular risk factors, and her examination was unremarkable. Her initial ECG showed a little bit of peaked T waves, a little bit of T wave abnormality inferiorly. Her chest x-ray was unremarkable. Her troponins rose. Her CT scan showed no pulmonary emboli, and she was started on heparin and transferred to our hospital for further evaluation and therapy. You can see on her repeat ECG when she arrived here, she had T wave changes anteriorly. And then she went to the cardiac catheterization laboratory, where you can see on her left anterior descending coronary artery an intramural hematoma, as well as in the posterior descending coronary artery. Both of those with TIMI 3 flow. So the plan was to treat her conservatively. Usually you want to keep someone in hospital longer than with a usual myocardial infarction. Normally now we are trying to get people out of hospital so much quicker, but in these patients, they really should stay in hospital longer for 4 to 7 days because of the risk of progression. She was started on aspirin, nitrates, and a beta blocker. And the question is, why do you want to do conservative therapy? Well, when you look at conservative therapy versus patients who undergo PCI, there is a very high risk of patients requiring emergency bypass surgery if you try and do PCI. And they can also have extension of of the lesion, as well as PCI failure at much higher rates than you would see with normal PCI. These failure rates and complication rates have gone down in more recent years as we've learned to be more aware of patients with spontaneous coronary artery dissection and have added imaging and other things to try and decrease our risk of complications. But failures still occur, and that's usually where you're unable to enter the true lumen with the wire, or you get loss of flow when you place a stent or do ballooning because of propagation of the dissection. So in this patient then, 2 days later, she had increased chest pain and ST segment elevation anteriorly. And there was some progression within the proximal vessel where you can now see a dissection flap here. And her PDA looked unchanged. So she had ballooning and stenting, and you can see that there were some issues as this occurred, and had stability of the dissection flap and did well afterwards. So what's the natural history of spontaneous coronary artery dissection? Well, when you do conservative management and follow these patients, about 17.5% of patients progress to have a critical obstruction. And that's while following patients. In that, about 91% occur within the first 6 days. And so the majority are here in this early time period. And that's why you want to consider keeping patients in hospital or warning them about the risk of progression. What are the risk factors for progression and patients having a complication? The biggest risk factor for this is isolated intramural hematoma. And you see that that has a threefold increased risk of progression compared to other factors. Other factors include high-grade stenosis, multivessel spontaneous coronary artery dissection, vascular FMD, and a long lesion length. And so again, this is why you want to think about keeping patients in hospital longer, even though you feel like you're not doing anything for these patients, because these are the concerns and you want to be able to rapidly treat someone. So I have a few examples here. This is a patient who had an intramural hematoma that's not really obvious. This then progressed on day 3, and that is it evolving into its dissection. When you look on OCT and look at the cap, you can see that it's very thin over the hematoma, and this is the area most likely to actually have the dissection as it propagates out. And so originally the thought was that the dissection was blood flowing into the blood vessel wall. It's now thought that it's more likely that it's the intramural hematoma that then ruptures into the blood vessel to alleviate the pressure from the bleeding in the blood vessel wall. And again, where there's the intimal tear is the thinnest layer that we typically see. In patients who have spontaneous coronary artery dissection by additional imaging, it appears that they also have excess vasa vasorum, so the small blood vessels that feed the coronary arteries are in excess, and that is associated with this bleeding into the blood vessel wall. So the patient was placed on aspirin and ticagrelor, metoprolol and nitroglycerin as needed. She had an echocardiogram with a normal ejection fraction. She had CT scans, which demonstrated mild fibromuscular dysplasia of the right renal artery, a genetic evaluation, and participated in cardiac rehab. So again, why not revascularize if you don't have to? This was a 32-year-old who presented to another institution with a non-ST elevation myocardial infarction. This is her cardiac catheterization, and you can see that there's a stenosis here in her obtuse marginal branch. And so they went to go ahead and treat this. They put a wire down and you can see them ballooning. And what you can see on the still frame of the ballooning is that you can see contrast now hung up in the left anterior descending coronary artery circulation over here. And so, excuse me, so then you can see that there's now a dissection all the way up the circumflex coronary artery. It's up into the left main. And it's going down the left anterior descending coronary artery, and there's now a stenosis in the diagonal branch, which was not present before this. And so this is one of the reasons why you want to be very cautious about doing interventions and really trying to leave that for patients who have an occluded vessel or poor TIMI flow. So again, for acute care, conservative therapy if possible. In looking at bypass surgery versus PCI, bypass surgery has better outcomes with long-term low graft patencies. When we go to classify spontaneous coronary artery dissection, type 1 has that radiolucent lumen that we always were looking for in the past. We now know that much more of spontaneous coronary artery dissection is seen as type 2 or type 3, with either diffuse stenosis seen generally at the distal vessels or a focal tubular stenosis. This focal tubular stenosis in the type 3 is more often missed, and all of us can do that. You coming in for a myocardial infarction, you see a lesion and you go ahead and put a stent into it, not realizing that it was actually spontaneous coronary artery dissection. So you want to think about particularly women, particularly younger patients who have no other evidence of atherosclerosis. You want to think, is this really atherosclerosis, and should I be treating it with a stent or not? This is another case. This is a 42-year-old female who was fit with no risk factors. She had a ventricular fibrillation arrest with full recovery and positive troponins. This is her electrocardiogram where you can see some T-wave abnormalities anteriorly. She again had a focal stenosis, which is really hard to tell what that actually is. And so normally you would want to do dual antiplatelet therapy, statin, and a drug-eluting stent. But if you go ahead and do OCT, you can see that this is an intramural hematoma. And therefore the diagnosis is spontaneous coronary artery dissection. So this changes your management. By now, you're not going to put in a stent. You don't need dual antiplatelet therapy, and that you want to look for other vascular abnormalities that are associated with SCAD. So when someone presents with spontaneous coronary artery dissection, they typically present with an acute coronary syndrome. About 50% of the patients have an ST elevation myocardial infarction. 10% present with ventricular fibrillation. In those patients who present with ventricular fibrillation, their ventricular fibrillation should be treated just as if anyone else who has a myocardial infarction. So using guideline-based directives, we have looked at our data here and have seen no advantage to putting in defibrillators in anyone who doesn't meet criteria, which is generally a low ejection fraction in follow-up or some other indication for an ICD. They're more often women. Postpartum is quite low, and they have associations with low other atherosclerotic risk factors and physical, emotional, and hormonal stressors. And when we talk about vascular abnormalities, most of the time we're talking about fibromuscular dysplasia, which is the most common association of vascular abnormalities. Most of the time, this is asymptomatic. Rarely is it symptomatic, but oftentimes will require some follow-up. But you can also see dissections in other blood vessels, and you can see aneurysms in all of the blood vessels as well. It's about 75% of patients have fibromuscular dysplasia when you do routine scanning for it. And generally you want to do CT scan, CTA or MR looking for it, but because ultrasound is not sensitive enough. When we tend to under-recognize SCAD, one of it is because when we look at a stenosis, we tend to think that it's going to be atherosclerotic, because that's what the vast majority of the time it is. And so that there's an assumption going in that it's going to be atherosclerotic. And so this is another case, 50-year-old woman, so kind of in the age group where it could be atherosclerosis, diffuse stenosis here. She came in with an acute coronary syndrome. And again, when you look by OCT, that narrowing is not atherosclerotic. It is, again, an intramural hematoma. The other assumption that comes in is oftentimes women who have had SCAD, it's been assumed that focal stenosis is spasm. When we looked at women who went on and got pregnant after having had SCAD, the vast majority of them had actually not had the diagnosis of SCAD at the time of their pregnancy. It was diagnosed as spasm, and so they thought they just had a coronary spasm, so that it was okay to go ahead and get pregnant. And so that some of these assumptions and some of this understanding is that you really need to make a diagnosis. This is a 49-year-old woman who came in with torsades and transient STT changes anteriorly. There's again a focal stenosis in the left anterior descending coronary artery. By OCT, you can see that it is actually SCAD. Under recognition of SCAD, again, the next factor that leads to misdiagnosis and missing SCAD is not paying attention to the distal blood vessels. This is where things can be missed because it's a small blood vessel and it looks just small or tapered off. And if you don't look for it, you won't find it. So this is a patient who came in with an acute coronary syndrome. And have you look at the posterolateral branch out here, where it looks narrowed and a little bit abnormal. And this is a still frame of it. Again, this is after intracoronary nitrates. Again, it's not spasm. Was thought to be generally normal. And when the patient came back for another angiogram because of chest pain, you can see that this vessel is actually much larger. And so this was a SCAD event. And it wasn't clear at the time, but when you can compare it with another angiogram in this patient, it becomes obvious that it was a SCAD event and the diagnosis was made. CT scans have often been advocated because they're less invasive, and so that some people want to utilize that for making the diagnosis. We know that when we go in and do a coronary angiogram in someone who has SCAD or a risk for SCAD, they actually have a higher risk of vascular complications from just doing the diagnostic angiogram. And so that if we could get away with it, that would be great. However, you can miss a SCAD event on CT scans. And so that we've seen negative CT scans in young women because of something that was just described as a small vessel or something that was described as motion artifact. And the small vessel is oftentimes the SCAD vessel, and motion artifact can actually be that you're missing the stenosis. And so CT scans, although can be helpful, do not eliminate the possibility of SCAD. And sometimes the angiogram just looks normal. And if the angiogram looks normal, just like with anyone who has a myocardial infarction with no evidence of a lesion, then you want to think about doing cardiac MRI, because oftentimes cardiac MRI will help lead you back to where the lesion was, so that if you weren't sure if this was the culprit lesion, you're not sure if that's the case, but you saw something that looked suspicious. If you do an MRI, then you can better correlate it back to that blood vessel, or you can use the MRI to direct you to look at some of the small distal vessels, and that can help you to make the diagnosis, because then you'll repeat looking at the angiogram after you have the MRI, also getting a second opinion and showing it to your colleagues, so that we are not shy at all here about showing films around, saying this looks a little funny to me, and then I'll show it to one of my colleagues without telling them what I see so I don't bias them, and then seeing if they think the same thing. And if everyone's getting caught on the same spot, it's most likely that it's abnormal. So this is a 32-year-old who presented with shortness of breath, chest pain, sweating, and had a positive troponin. This is the coronary angiogram. You can see that it does not look all that impressive. This is the right coronary artery, which looks very impressive. And this was her spontaneous coronary artery dissection. So she was known to have a spontaneous coronary artery dissection. This is her vessel that they re-imaged a few days later. 3 years later, I got a call about this patient who I followed, that she had a troponin positive myocardial infarction, and they said the cath was normal, perfectly normal, everything looks great. And actually the provider actually sent me, tried to send me still frame images, and I said, no, you got to send me the whole cath, because I'm not going to take a still frame images. And then when we looked at the cardiac catheterization, and you look at her left anterior descending coronary artery, the diagonal branch right here, off of it, you can see that this is a narrow, funny vessel. And when you compare it back against her prior, it's clearly abnormal. And so that's where her spontaneous coronary artery dissection was on the repeat. And especially in someone like this, you have to assume that there was a repeat SCAD. So this would be another place that if you couldn't make the diagnosis by her angiogram, then going ahead and doing an MRI and looking back to see where it led you to would have likely led you to that vessel. Other clues you want to think about is tortuosity. And these are pictures of numerous patients who've had spontaneous coronary artery dissection. And you can see how curly-cued the vessels are. They essentially look like a patient who's much older with hypertension. And that's where normally we would see a lot of tortuosity in the vessels. But in this circumstance, it's just associated with spontaneous coronary artery dissection. There's some suggestion that the abnormalities in the blood vessel wall may lead to increased growth factors being secreted, and the blood vessel trying to grow to try and compensate for the abnormalities in the blood vessel wall, which is what leads to this tortuosity, but that is still speculative. So when you look at tortuosity, it's been shown that patients who have SCAD versus controls have greater tortuosity in all of their vessels. It's highly prevalent in SCAD. Interestingly, it is not associated with SCAD that's associated with peripartum SCAD. It's unaffected by hypertension. It's most prevalent in patients who also have vascular fibromuscular dysplasia, and it's a predictor for recurrent SCAD. You also can have an FMD appearance in the coronary arteries associated with people who've had SCAD. This is an FMD appearance, and it has a very low likelihood of appearing of 0.2%. And you can see the abnormalities in the blood vessel wall by IVUS, and that is growth abnormalities there. And this is by OCT. Again, you can see the more cavernous areas that are associated with the intramural hematoma, and subsequent SCAD. When a younger woman has an acute coronary syndrome, again, you're going to start to think about whether or not you're dealing with SCAD. This is, again, a lesion in the left anterior descending coronary artery. It's a little bit hazy looking. And when you look at it under OCT, you can see that there's actually mild atherosclerosis out distally. Then you can see some thrombus. And then you can see severe atherosclerosis more proximally where the lesion is. And so this patient has atherosclerosis and needs to be treated appropriately for that with a stent and all the good therapy that we know works with atherosclerosis, including aggressive lipid lowering therapy, dual antiplatelet therapy, beta blockers, etc. So there is the risk, although we keep talking about not missing the diagnosis of SCAD, there's also the risk of overdiagnosing it. And so don't be fooled in the other direction as well, and making sure that you make the diagnosis when it is atherosclerosis. This is a 32-year-old woman, had chest pain on exertion and at rest beginning at the age of 28. She had mild hyperlipidemia. Her father died early of a myocardial infarction. She had 4 ER visits with troponin-positive chest pain, a normal echo, and that is her catheterization with the left anterior descending coronary artery. 4 weeks later, she had more chest pain, and you can see that now there's a lesion up higher. And the area down below looks normal. And 1 month later, the vessel is actually occluded. After intracoronary nitrates and verapamil, it normalized. And when you do further imaging of it, there is mild atherosclerosis, but no intramural hematoma. And so the patient actually just had profound spasm causing myocardial necrosis. Again, something that you don't want to miss. And again, something that you're not going to want to be stenting for. This is a 51-year-old woman with an ST elevation, myocardial infarction, and ventricular fibrillation due to SCAD. And you can see that there is a lesion in her distal left anterior descending coronary artery with poor distal flow. This was treated with ballooning only, and you can now see the dissection plane in the vessel, but the flow has actually normalized. And if someone's hemodynamically doing well after just balloon results, then leaving a balloon result only is an excellent option, because we know that these SCAD lesions will heal up over time. So the vast majority will heal, and you actually will not be able to see where the lesion was, and so that it decreases the risk of complications associated with having a stent in place, and also leaves options where you're not stenting in a distal left anterior descending coronary artery, which could preclude bypass surgery into the future, especially in a patient so young. This is another case. This is a 45-year-old with acute coronary syndrome due to SCAD. The patient was pain-free with TIMI-free flow, treated with cabbage, and repeat angiography that 1 year later showed that the left main looked perfectly normal, and the grafts had occluded. So when you look at patency of grafts, cabbage is a great option for restoring flow and giving great outcomes from patients acutely. But long-term, the grafts really don't stay open, because as the SCAD vessel heals, then there's no need for the graft. And so the graft has a low flow and closes because of the lack of flow. So we tend to think of patients with SCAD as having vulnerable vessel walls, then they also seem to have a circulating milieu that's associated with it, which is part of why you can get SCAD in multiple coronary artery vessels and multi-vessel SCAD at the same time. We've also seen SCAD in associated with cerebral dissections. And so that bodes to that there's something additional systemically that's altering to increase the likelihood of having a dissection. And then there's also physical and systemic triggers. Spontaneous coronary artery dissection tends, again, to be in healthy women, tortuous coronary arteries, and fibromuscular dysplasia. You want to focus on mechanisms which appear to be both the blood vessel wall as well as genetic and circulating factors. You want to try and keep with conservative therapy with aspirin and beta blockers, and you want prolonged observation, especially if there's a diffuse lesion and an intramural hematoma. If you need to revascularize, you can do PTCA alone, you can do bypass surgery, you can do stenting if you need to. So now let's move on to talking about what happens when the patient comes back, and now they're being seen as an outpatient. And these are all the factors that I tend to try and go through when I see someone in the outpatient arena who's had SCAD. You want to talk about medications and risk factor control. So you want to look at beta blockers, aspirin, and nitrates if they're having chest pain. You want to make sure that they get vascular imaging. The most important imaging is the abdomen and the pelvis and head and neck. The chest, although can be additive, has a much lower likelihood of having vascular abnormalities. Again, you want to do this by CTA or MRA. You want to discuss hormones and pregnancy. You want to go through exercise and cardiac rehab, genetic factors and genetic screening, discuss the recurrent risk, and discuss mental health. And so I will go through each of these factors in the next several slides. When we talk about risk factor management, what has been shown from Jacqueline Saw's data is that patients who have hypertension and spontaneous coronary artery dissection are at higher risk of recurrent SCAD. And so when you think of the vulnerable blood vessel wall having hypertension, is something that then is triggering against a vulnerable vessel. And so that trying to minimize hypertension and have your blood pressure even better controlled than normal is likely ideal. What kind of medications should these patients be on? Well, again, in Dr. Saw's data, looking at beta blocker therapy, patients who were placed on beta blockers tended to have a lower likelihood of recurrent SCAD. And so beta blockers tend to be effective therapy. Aspirin was beneficial on univariate analysis, but not multivariate analysis. And so most of the groups are still utilizing aspirin in patients, but we explained to them that there isn't a huge benefit with aspirin, and really no other therapy has been shown to be beneficial. In a small series from our first study, statin therapy was associated with adverse events and was associated with increased SCAD recurrence. It has not been shown in larger studies. So we really only put people on statin therapy if they would otherwise meet criteria to be on statin therapy without having a myocardial infarction. So we don't utilize their myocardial infarction from SCAD as calculating into their risk score. Additionally, because you've done CT scanning or MRA of all of their vascular vessels, you also know if they have any atherosclerosis. And so if there's atherosclerosis or something else to push you to put someone on a statin, that's fine. And then we put them on statins, but we don't do it just because they've had a myocardial infarction. Again, you want to do the vascular imaging, more so to look for aneurysms and other dissections rather than looking for fibromuscular dysplasia. About 2/3 have some sort of vascular abnormality. And usually it's fibromuscular dysplasia. Again, these are associated with increased risks of recurrence with their SCAD. So what about hormones and pregnancy? Usually we recommend against any hormonal therapy, and we recommend against pregnancy. Hormonal therapy is really associated, that recommendation comes because of the increased clotting risk that we see in patients who are on hormonal therapy, also because 10 to 20% of SCAD occurs peripartum, and we don't fully understand what hormones are involved. We think that hormonal therapy is generally to be avoided. And so that's the usual recommendations. The exception to that is an IUD with hormones because of the small dose of hormones associated with an IUD. An IUD is an acceptable way to prevent pregnancy. In the peripartum SCAD, it's often multi-vessel. It also often involves the left main. They tend to have lower ejection fractions and more ST elevation, so it's a higher risk kind of SCAD. So generally, we would recommend against having a repeat pregnancy. We have seen plenty of women who have had pregnancies after they've had a SCAD event, and women who are trying to make a decision about whether or not they want to carry a pregnancy. If they've accidentally gotten pregnant after having had a SCAD, and so that there are ways to help manage women through their pregnancy. When we have looked at the risk of someone having a recurrent SCAD event, it's only about 9% with a repeat pregnancy. And when we compare that against a population, against patients who've had SCAD who have not gotten pregnant again, the risk is unchanged. And so that we don't think that there's an overwhelming risk with recurrent pregnancy, but the recommendations remain that avoidance of pregnancy is probably ideal. What about exercise and cardiac rehabilitation? When we did data looking at patients who have had SCAD, the thought was that most of these people were going to be young, fit patients. We all think about the patient who's exercising huge amounts, is thin, they have a low blood pressure. But when we looked at all of these patients, actually only 40% of people who have had SCAD were already achieving current exercise recommendations prior to their SCAD, with 49% exercising 3 times per week or more. And so really, there are a number of people who have SCAD that actually are not all that fit. And so that getting them into cardiac rehab is very beneficial. You want to, in these patients, avoid traumatic and highly competitive activities, so that avoiding trauma from like bungee jumping, parachuting, highly competitive sports, in part because people tend not to listen to their bodies when they're competing in marathons and other races. You want to avoid straining and Valsalva maneuvers. So weightlifting is fine as long as you're not straining with it. In our study, 77% of patients with SCAD were referred for cardiac rehab and went to it. Usually the advice they had been given was really on lots of limitations, and excessive limitations on exercise really should be avoided because it's preventing good cardiovascular health without any clear evidence of benefit. So that there are no limitations based on heart rate, there's no limitations based on how far you can run or walk. It's really someone listening to their body. Aerobic exercise is generally not limited except for extreme weather conditions and extreme sports. Other than that, good vigorous exercise is encouraged. So what about genetics? We tend to also refer all of our patients with SCAD for genetics and genetic testing. When we have looked at families with SCAD and other people with SCAD, we have found specific genetic variables that are associated with SCAD. And so there definitely are genetic factors at play. When you look at clinical genetic packages, that is what we do from a clinical standpoint. In Mass General's study looking at their patients with SCAD, they found 8.2% of patients had some sort of molecular vascular disorder. And so that it can be very beneficial for patients to look for these disorders, and it increases their screening to also go along with the vascular disorder that has then been identified. It can also help with family screening as well. One of the other things about SCAD, and one of the things that is always worrisome for patients who've had SCAD, is what about the risk of recurrence? Once upon a time, people were always told that if they had SCAD, it was like lightning hitting, wasn't going to occur again. Now that we've had larger series of patients with SCAD, we do know that it does recur. The recurrence rate is about 18%, and that's in those patients who are followed, and the average follow-up time is 5 to 8 years. When you compare patients who have SCAD versus patients who've had acute coronary syndromes for atherosclerotic causes, patients with SCAD do better over the long term, and that's been shown in multiple studies. What about mental health? We've recently published data on mental health and associations of mental health disorders that occur after having had a SCAD event. About 82% reported this as a traumatic event. 28% on screening questionnaires had mild to moderate PTSD. 41% reported anxiety, 32% depression. And these factors were all associated with a younger age and lower resilience index, so that the younger patients who haven't had any major health concerns now have had something that they deem very important and very overwhelming. Even though most of the time the ejection fraction has normalized, heart health-wise, they're doing very well, they feel petrified that this might happen again. And so there aren't great data on treatment outcomes of mental health and its association with how someone does with SCAD, but from a quality of life standpoint, it's certainly important. And when we look at other myocardial infarction data with treating depression and anxiety, with positive outcomes to treating mental health issues, this is likely to be very important. So in summary, angiography is the gold standard for diagnosis, but MRI, IVUS, OCT, CTAs can all add value. And so that sometimes if you're not sure, getting more information is always helpful. PCI can be beneficial, but there's unique complications, including propagation of the lesion. Intramural hematoma in isolation has a higher risk for extension and may precede the intimal tear. In the acute management, chest pain with SCAD does not always mean ischemia. And so that just from the dissection, people can have some ongoing chest pain. We tend to treat it with nitrates, but you want to really act on someone based on ECG changes and angiographic findings, not just that they're still having some chest pain. If the blood vessel looks stable with normal flow, you want to lean towards conservative therapy, knowing full well that approximately 1 out of 5 will go on to progress. You want to utilize aspirin and beta blockers, no statin unless indicated, no heparin or warfarin. You want prolonged observation, especially with diffuse lesions and intramural hematomas. And if they are unstable, you need to revascularize. And that can be by PTCA stents or bypass surgery when appropriate. In follow-up, you want to make sure you're screening for vascular abnormalities. Think about genetic testing, avoid hormones in pregnancy, give recommendations on exercise and cardiac rehabilitation. Oftentimes you need to give the recommendations to cardiac rehab as they're not sure what to do in this unique population. and you want to counsel on recurrence and lots of reassurance because the mental health aspects of it. Thank you so much, and I'd be happy to take any questions.
Thank you, Dr. Best. That was absolutely fantastic and a really nice comprehensive review. And I love the images and case-based.
Good.
Thank you for waking up so early to give the rounds
Yeah.
also.
I was going to say, yeah, it's an hour earlier here. So yes, thank you.
So let's see if our audience has questions. Please type them into the chat. This is it's very interesting. I mean, the problem of persistent and recurrent chest pain and SCAD, how are you handling sort of, if somebody's already had an event and they keep having recurrent chest pain, what is your approach for these patients?
So I have some really important thoughts on recurrent chest pain. So if they're having recurrent chest pain, that's not an acute coronary syndrome, that they're just having chest pain, that they're reporting to you that daily they're having chest pain or something, you want to think about, number one, is the blood vessel that was where the SCAD was, is there any ischemia associated with it? So sometimes if something wasn't opened or something wasn't treated, they're still having cardiac ischemia. So that's the first question, is there a complication with something that was treated? Is there something that wasn't treated that's not normal? The next question I always have is, do the patients have pericarditis? I have not yet seen, but I think that there may be a higher incidence of pericarditis associated with SCAD. And I have found patients with SCAD, even out past a year, who've come in and had repeat coronary angiograms and other things because of their chest pain, that they actually had pericarditis and it was missed. And so usually I get an MRI looking for pericarditis, because treating that obviously is a different scenario. We also have some people who seem to have more endothelial dysfunction after their SCAD event. And so we also can test for endothelial dysfunction and treat that appropriately. And so those are usually the main things that I'm looking for. Early on, sometimes it's just the healing of the blood vessel wall. So you will hear some people say, yeah, they continue to have a little bit of chest pain through the first couple of weeks and then it disappeared. And that's probably just the dissection healing.
Mm-hmm. So when you say test for endothelial dysfunction, do you mean with acetylcholine or do you mean peripheral arterial tonometry?
I mean acetylcholine in the catheterization laboratory.
And you don't worry about,
I worry with everything. So the answer is yes. But yes, we still do it and you can do it safely. But yes, do I worry? I worry every time I cath someone who has SCAD. So yes, I worry about it. But, if you need to make a diagnosis and you need to know what you're treating, then, and someone's having enough chest pain and enough problems from their chest pain, then I think it's worth it to get an answer. So yes, we'll do acetylcholine.
And would you do it in a different vessel than the one that they had their SCAD event in? So if it was the LAD SCAD, would you do acetylcholine in the circ?
So not necessarily. Usually if you're going to do acetylcholine, you're going to do it far enough away from when they had their initial SCAD. So you're not doing it early. You're waiting, months to years afterwards. And so generally, even if that was the LAD was the vessel that they had their SCAD event in, it will be well healed up.
Okay, great. There's a question from Dr. Lundberg. Would you suspect that stroke with carotid dissection 2 weeks postpartum is a variant of SCAD? And what are your recommendations long-term?
So I would suspect that does relate to the same milieu associated with SCAD. And so that our neurologists, when they see a carotid dissection, a spontaneous carotid dissection, they're less aggressive about doing scanning head to toe. So I would do the scanning head to toe. Again, I would do a genetic screening in that patient. I wouldn't look necessarily for coronary SCAD or coronary FMD or anything else. I would just be looking for the other vascular abnormalities. And then usually they get follow-up based on the carotid dissection, and so that there's usually repeat imaging to look at it healing and to make sure that there's stability and no compromise from a vascular standpoint. So depending on who the neurologist is, it's usually at 6 months to a year.
Thank you. What are your thoughts about statin so let's say you've done OCT, there's no, clear sort of a high atherosclerotic burden. And if it's a young woman who's had SCAD, what is your approach in terms of statins?
So if you utilize your risk scores to place patients on statins, take away that they've had a myocardial infarction. So anyone who would have enough risk factors to put them on a statin without the myocardial infarction should go on a statin. And so that we still have patients who are on statins. Usually they're patients who've had hyperlipidemia, that some of them were on statins before their SCAD event. Those kinds of patients should be on a statin, but you shouldn't utilize the myocardial infarction as we normally do, which is you had a myocardial infarction, you should go on a statin, because that's with atherosclerosis. With SCAD, it really should be thinking of it really in prevention of future atherosclerosis, which is not what they've had an event for.
So prior sort of signal to avoid statins in SCAD patients, is that sort of not the current?
So our signal, when we saw it, we only had about, I think it was about 85 patients in our registry, and we saw that signal. It has not been seen in larger series or subsequent follow-up of that. So that's probably an artifact from having a small sample size. So I don't know that I believe that it's a risk, but I also don't think that it's likely a benefit either. And so that if you have a young person that you're putting on a medication long-term, and they're not likely to have benefit from it, because we've seen no signal of it being beneficial, and they otherwise shouldn't meet criteria to be on a statin, I don't know that they ought to be on it. And so that I'm not as convinced that it's harmful, it's likely not beneficial.
Thank you.
You're welcome.
Any other questions from?
Hey, Patricia.
Yes. Hi, Dr. Clements. Go ahead.
Patty, that was very good. So I guess we all try to figure out how to diagnose this before we get in the cath lab, right?
Yep.
But actually, we don't do that very often.
Nope.
The key to that, it seems to me, from all the great stuff that you presented, is the patient profile. And if we kind of get that patient profile right, and as a young woman with chest discomfort, not always a woman, and we got to put that on the list. And if we see, first of all, what we think are normal coronary arteries, and then second glance, a slight narrowing, then our suspicion goes up.
Yep.
So once we start looking for that, we might diagnose it before we shoot those arteries. But we don't do that too often.
I guess I'm not opposed to shooting the coronary arteries, because I think that's still the best way of making a diagnosis.
Yeah, absolutely. Absolutely.
You know, I think really, and I've got to say, I'm going to admit my own flaws and mistakes of, I too, like every other interventionalist, has seen a focal stenosis in someone and was gung-ho and put a stent in it. And then when they came back with their recurrent dissection, we made the diagnosis that I likely shouldn't have put that stent in the first place with their previous myocardial infarction, because that was likely a dissection as well. And so that in those circumstances, you know, when we're coming in for an acute coronary syndrome, we're all gung-ho, ready to go, and not thinking about as much, do I have the right diagnosis? And I think working on having everyone thinking about it a little bit more, then you could IVUS it, then you can do OCT, you can rethink about, is there any other coronary disease? And then you don't need to put a stent in if that's the case. And then you're also going to do all the other screening and treat more appropriately for that patient.
That's correct. So
Yep.
That was very good. I'll tell you that this is the third time this year, Pooja, you can listen to this, that
Yeah.
we've had SCAD presented twice by our fellows and now once by the real pro you. And interestingly, all of your angiograms complemented what everybody else presented, and your presentation, all three of them complemented each other. So
Oh, nice.
after these three, maybe we will diagnose it in the emergency room
Right.
one time. Okay, let's go to the cath lab and try to prove it.
Yep. You know, it's like when you have apical ballooning, you know, and you're suspecting apical ballooning because of all the right scenarios. Oftentimes they still have to come to the cath lab to make the diagnosis. And
Absolutely.
so I'm not opposed to shooting it and you know, shooting the pictures, but then it's what you do with it that I think is more important.
Great. Thanks so much.
Thank you.
So, what do you do for patients who, let's say that, you know, somebody at an outside hospital had a troponin leak, you have the report that cath was normal or no obstructive CAD, and then they're in your clinic. Do you get a CCTA to look to see if there was a dissection?
So the first thing I do is I require that I see everyone's angiogram. And so
Yeah.
like the one that I showed you from a patient who I'd followed as an outpatient, and I was told they had another myocardial infarction, but it was normal. I don't believe anyone's normal. And if I don't see anything, then I usually show it to someone else, so that if I don't believe they're normal, I then also make sure someone else also says they also think it's normal. So I don't know that doing a CT scan at that point is going to be helpful, because if you didn't see it off of the angiogram, which has more sensitive imaging of the coronary arteries, you're very unlikely to see it by CT scan. So then the next thing I would do, because that's then just a Minoka patient, is then the next thing I find most helpful in Minoka is actually getting an MRI to see, did they have an infarct? And then from that, going back to look at the coronary angiogram to see if I can find something that looks abnormal from it. So to me, that's what I would do with a Minoka patient, whether or not it's SCAD or not. And so, so that's where I would start. We've seen CT scans that, you know, we had someone who she had VFib arrest actually here in our hospital. She was visiting her grandmother who was ill. She had a VFib arrest, and hers was actually a SCAD, but it was missed off of the CT scan because they tried to rule everything out because she was young, and look for other causes, and it was missed here as well. And so the CT scan, although it's helpful, I don't know that at the current time it's adding as much value. And I certainly wouldn't preclude someone who's having an acute coronary syndrome from going to the cath lab, even if I think it's likely to be SCAD.
Okay, great. Thank you so much.
You're
Any
very
other questions from anyone?
Yes, it's Peter Block. Can I ask
Yes.
a quick question?
Absolutely.
You know, when we deal with dissections otherwise in the aorta commonly, as you know, the worry is not so much about the intramural hematoma as it is that it's going to leak. And I have never heard of a case of SCAD that leaks into the pericardium. Have you ever seen that, number one? And then the other side of it is to avoid that, at least in large vessel dissection, we always give beta blockades and maybe some aspirin. But what do you do for patients that are beta blockade intolerant? Because unloading them obviously is not the right thing to do.
Right. So I've never seen anyone with a leak into the pericardium associated with SCAD. Could we have missed it? It's possible, because if you saw someone with a hemopericardium, I don't know that you would have necessarily went back and thought, gee, did they have SCAD? You would be thinking of other things, and I don't know that we would shoot the coronaries in that circumstance. So I have never seen it, but that doesn't mean it doesn't exist. And then, you know, the beta blockers, that makes sense from the standpoint of what also is effective in aortic dissections, that beta blockers are helpful. We definitely have a population of people with SCAD who have very low blood pressures to begin with, and they don't tolerate anything to lower their blood pressure. Certainly now with some evidence that beta blockers are helpful, we try and get them on a little bit if they can tolerate it, but if they can't tolerate it, you go without. Usually we try and push a little bit more on the early time period after their MI, probably with the greatest benefit at that time point, but it's not clear. And again, some individuals have such low blood pressures, they just really won't tolerate any.
We need something more magic than just beta blockade.
Yes, we do. I can't wait.
Any other questions or comments? Okay, well, we are at 8:30. So thank you again, Dr. Best. That was absolutely fantastic. And we learned a lot. So thank you so much.
Thank you so much for having me.
The preceding program is copyrighted by Emory University.